Defensive documentation in psychiatric practice, closing legal vulnerabilities while maintaining clinical efficiency. The practice of psychiatry exists within a peculiar tension, the imperative to provide comprehensive, nuanced care while simultaneously protecting oneself against legal challenges that may emerge years after treatment concludes. Unlike many medical specialties where objective findings predominate, psychiatry operates largely in the realm of subjective experience, clinical judgment, and therapeutic alliance, precisely the domain most vulnerable to legal scrutiny. This essay examines the common vectors of malpractice claims against psychiatrists and proposes strategies to minimize legal exposure while maintaining the delicate balance between thorough documentation and sustainable clinical practice. The landscape of psychiatric malpractice. Malpractice claims in psychiatry typically coalesce around several recurring themes. Understanding these patterns allows clinicians to anticipate vulnerabilities and implement protective measures without succumbing to defensive medicine that compromises patients' care. Diagnostic accuracy represents perhaps the most frequently contested domain. Plaintiffs, attorneys often argue that an incorrect delayed diagnosis led directly to patients' harm, whether through prolonged suffering, treatment resistance, or catastrophic outcomes. The challenge lies in psychiatry's diagnostic ambiguity. Unlike a radiograph revealing a fracture, psychiatric diagnoses emerge from symptoms constellations, longitudinal observation, and clinical inference. A patient initially presenting with apparent unipolar depression may later manifest bipolar disorder, not necessarily because the clinician was mistaken, but because the illness evolved and revealed itself gradually. Treatment selection. That follows closely behind diagnostic challenges. Lawyers frequently argue that a provider recommended inappropriate interventions, whether prescribing antidepressants to someone who proved later to be a bipolar patient, or choosing medication with unfavorable side effect profile when alternatives existed, or failing to pursue psychotherapy when pharmacotherapy alone proved insufficient. The retrospective bias inherent in legal proceedings transforms reasonable clinical decisions into apparent negligence when outcomes prove unfortunate. Availability and accessibility constitute another common attack vector. Claims emerge that the psychiatrist was insufficiently available, failed to return calls promptly, or did not establish adequate crisis protocols. In an era of packed schedules and limited appointment availability, demonstrating appropriate responsiveness becomes crucial. Related claims focus on the absence of clear mechanisms for urgent communication, situations where a patient in crisis cannot reach their provider and subsequently deteriorates. Informed consent represents a particularly treacherous domain. Plaintiffs argue that they were inadequately informed about medication risks, side effects, or alternative treatments. The legal standard requires not just mentioning risks, but ensuring genuine understanding and documenting that understanding. Claims assert that patients weren't given the opportunity to ask questions, weren't presented with alternatives, including the option to refuse treatment, and weren't informed about the probabilistic nature of psychiatric interventions. Failure to prevent suicide remains the most devastating claim psychiatrists face. Lawyers scrutinize whether the clinician adequately assessed suicide risk, asked sufficiently probing questions to uncover suicidal ideation, recommended appropriate intensity of treatment, suggested hospitalization when indicated, or initiated involuntary commitment when criteria were met. Each missed appointment, each unreturned call, each clinical decision not to hospitalize becomes potential evidence of negligence when examined through the lens of a completed suicide. Beyond these primary categories, malpractice claims invoke numerous additional theories: failure to obtain adequate history, including family psychiatric history and previous treatment responses, inadequate monitoring of medication effects or side effects, failure to recognize and manage emergent medical complications, inappropriate boundary violations or dual relationships, premature termination of treatment, failure to coordinate care with other providers, inadequate supervision of mid-level practitioners, failure to warn third parties of patients' threats, inappropriate breaches of confidentiality, and failure to recognize when a case exceeds one's competence and requires referral. The documentation paradox. These vulnerabilities give rise to a seemingly straightforward solution: document everything comprehensively. Yet here emerges the central paradox of psychiatric practice. The maxim, if it's not in the chart, it didn't happen, reflects legal reality. Without documentation, even excellent care becomes indefensible. However, insurance companies universally refuse to compensate clinicians for documentation time, creating an economic impossibility. The expectation that clinicians provide uncompensated labor to protect themselves against legal claims. This paradox intensifies given appointment structures. A typical psychiatric follow-up appointment lasts 15 to 30 minutes. To make documentation legally defensible while maintaining clinical viability requires that the chart notes consume only a fraction of this time, perhaps 5 to 10 minutes. Yet comprehensively documenting diagnostic reasoning, risk assessment, informed consent discussions, treatment alternatives considered and rejected, rationale for medication choices, side effects monitoring, psychoeducation provided, crisis protocols established, and coordination with other providers could easily require more time than the appointment itself. The solution lies not in abandoning comprehensive care, but in strategic documentation that captures essential elements while accepting that perfect legal protection remains unattainable. The goal becomes maximizing protection per minute of documentation time. Strategic documentation, efficiency with protection. Diagnostic formulation should be documented concisely but completely. Rather than lengthy narrative, employ structured formats. Diagnosis of major depressive disorder based on 9 months history of depressed mood, anhedonia, sleep disturbance, appetite change, fatigue, concentration difficulties, passive suicide ideation, no manic symptoms on direct questioning, family history of unipolar depression. Considered but ruled out bipolar disorder. No manic symptoms, no antidepressant-induced mania. PTSD, no trauma history, medical causes, recent lives unremarkable. This paragraph requires perhaps 60 seconds to dictate but demonstrates systematic diagnostic thinking. Treatment rationale deserves similar structured attention. Recommended sertraline 50 mg daily. Discussed with the patient expected timeline for response, common side effects, management strategies, alternative medication available if ineffective or poorly tolerated, role of psychotherapy as adjunct or alternative. Patient expressed understanding and agreement. Declined therapy referral at this time but open to reconsideration. Risk assessment demands consistent documentation, particularly regarding self-harm. Suicide risk assessment, for example, denies current SI, denies plans, acknowledges past suicidal ideation during worst depressive episodes but states current symptoms improved. Protective factors, strong family support, employment, future orientation, safety plan reviewed, identified warning signals, coping strategies, emergency contacts, including crisis line and emergency department. Instructed to contact me if suicidal ideation emerge. No current indication for hospitalization, outpatient treatment appropriate. Crisis protocols should be explicitly documented, patient educated regarding after hours contact procedures. Office phone reaches answering service 24/7. For urgent clinical issues between appointments, leave detailed message and expect a call back within 3 hours during business hours, longer evening or weekends. For psychiatric emergencies, proceed to ED or call 988 or 911. Informed consent need not involve transcribing entire discussion, but should capture key elements. Discuss risperidone for persistent psychotic symptoms, potential benefits, common side effects, including sedation and weight gain, risk of metabolic syndrome, requiring monitoring, risk of EPS and tardive dyskinesia, alternatives, including other antipsychotics and psychotherapy intensification. Patient expressed understanding, asked questions about tardive dyskinesia risk, which I addressed. Patient consented to the trial. Clinical decision making regarding hospitalization and intensive services deserves explicit documentation when considered but not pursued. Discussed partial hospitalization program given depression severity, patient decline, citing work obligations. Patient retains capacity for treatment decisions. Negotiated increased appointment frequency as alternative. Patient agreed to twice weekly sessions for the next 2 weeks. Clear safety parameters established. The art of selective comprehensiveness. The most sophisticated documentation skill involves knowing what must be captured versus what can be abbreviated or omitted. Certain elements require explicit documentation in virtually every encounter. Suicide risk assessment, medication changes with rationale and informed consent, crisis situations or significant clinical deterioration, decision not to hospitalize, consultations or referrals recommended. Other elements can be documented more efficiently through templates, checkboxes, or brief notations, updated only when changes occur. For example, current medication and dosage medication side effects, screening, substance use status, living situation and support system, employment or functional status. The clinician might employ a structured template for routine follow-up that includes essential elements while allowing narrative elaboration where clinically or legally significant mental status examination findings, medication adherence and tolerability, symptoms trajectory, safety assessment, plan modifications. This approach ensures no critical domain is overlooked while permitting focused attention on clinically relevant developments. Beyond documentation, systemic risk reduction. Documentation alone cannot eliminate malpractice risk. Complementary strategies include maintaining accessible crisis protocols with clear instructions for urgent contact, establishing collaborative relationships with emergency services and hospitalization facilities, utilizing validated screening instruments for suicide risk, depression severity, or functional impairment. Their numerical scores and structured domains provide objective documentation, engaging patients as partners in treatment planning, documenting their preferences and decisions, pursuing ongoing education in evolving standards of care, maintaining professional liability insurance with adequate coverage, consulting colleagues regarding complex or high-risk cases, documenting these consultations and knowing one's limitations, referring when cases exceed expertise. Imperfect protection in an imperfect system. No documentation strategy provides absolute protection against malpractice claims. Psychiatry involves inherent uncertainty and tragic outcomes occur despite excellent care. The goal is not perfection, but demonstrating that one's clinical decision-making met the standard of care, that diagnosis emerged from systematic evaluation, treatments reflected evidence-based practice and informed consent, risks were assessed and addressed appropriately, and the patient received care consistent with a competent, careful psychiatrist's approach. The tension between comprehensive documentation and sustainable practice will not resolve until healthcare economics recognizes documentation as an essential clinical work component deserving compensation. Until then, psychiatrists must master the art of strategic documentation, capturing the elements that demonstrate sound clinical reasoning and appropriate care, while accepting that efficiency demands some degree of incompleteness. The chart need not chronicle every word exchange and every thought considered, but it must demonstrate the essential components of psychiatric care were delivered thoughtfully, collaboratively, and in accordance with professional standards. In this imperfect compromise lies the pragmatic path forward for clinicians committed to both excellent patient care and professional survival.